pharmacokinetics, isn't it? So excretion of the drugs may
Excretion.
get delayed. So you
The
may have to
prolonged
reduce the dose of the drugs which depend on
renal excretion.
complete excretion through the kidneys. So that is one thing. Okay, anything else as far as kidneys are concerned?
Hepatic blood
Nephrotoxic
flow.
nephrotoxic drugs have to be avoided.
No, that is there. That already you have discussed. What about they may also have some obstructive uropathies,
Yes, sir.
especially male patients.
Male patients.
Yeah,
Prostate are more common in old age patients.
isn't it? TURP, they do come for
TURP is more
very
common.
common. And obstructive uropathy is very common. Urinary retention. Postoperatively, for example, now a patient, let us say that you have done a cataract surgery. Patient has become very restless in the postoperative period. He can have a urinary retention. Patient may be having restlessness because of the urinary retention. Even many of these patients can develop postoperative, severe restlessness and then uncooperative behavior, isn't it? So that may be because of just bladder that is distended. So that is another problem with genitourinary system. Okay. So what about the excretion of sodium and retention of water, anything regarding the renal system? They develop more commonly, the hyponatremias are common in these patients.
Yes, sir.
Now, why
Old age.
hyponatremia is very common in these patients?
Excessive sodium excretion.
Is it excessive sodium excretion or more water retention?
Retention.
Now, many of these patients usually they have altered mentation and they're admitted to the hospital, isn't it? You just check a sodium and sodium level invariably will be on the lower side. Their sodium correction is done, they become all right. And it is mainly because of probably the increased secretion of ADH in these patients. Antidiuretic hormone, more amount of it is secreted. So that is how, there will be more water retention. So whenever there is more water retention, dilutional hyponatremia. And hyponatremia is very common. So electrolyte studies have to be done in these patients. That is very common. And again, many of these patients may also have hypertension, very common, like your patient is already having. They may also have diabetes. So because of that, they may have a nephropathy as a result of either hypertensive nephropathy, diabetic nephropathy, obstructive nephropathy. Many of these things can be there. So they may have, decreased renal functioning and including probably renal failure also can be there. It is very important to assess these patients. What about the creatinine in these patients?
Creatinine will be normal, but the clearance is reduced.
When clearance is reduced, how creatinine can be normal? No, creatinine depends on what actually?
Serum plasma.
No, creatinine depends on the muscle mass.
Muscle mass.
Isn't it? That is why, in Cockcroft's and Gould's equation, we always take age into consideration. Isn't it? 140 minus age in
40
years.
minus age
Body weight divided by serum creatinine.
by 72.
Yeah, that is what we
Into
always.
serum creatinine.
So age is very important because the muscle mass decides what is the amount of creatinine. What happens to the muscle mass in these patients?
Reduces.
Skeletal muscle mass is reduced. That's why, though the creatinine clearance is reduced, the creatinine levels will be normal only. And any increase in creatinine more than 1, you can take it as raised. Because they are supposed to have a lower creatinine levels because of decreased, muscle mass.
And clearance.
Okay. What about the hepatic system?
Hepatic blood flow is reduced, and the hepatic metabolism is also altered.
Now, which particular, is it phase 1 is affected more or phase 2 is affected more in the liver? There are two kinds of metabolism, isn't it? Phase 1 metabolism and phase 2 metabolism. So, because the liver also shrinks, everywhere all organs will shrink. Isn't it? That is what we call it as homeostenosis. The functioning of all the organs will come down. The anatomical the size of all the organs also will come down, which we call it as homeostasis. The liver size also decreases by almost 30%. Kidney size decreases by 30%. And because liver size is decreased, the liver functioning is also decreased. And in that, there are two kinds of metabolism, phase 1 and phase 2 metabolism. Which phase is affected more? It is the phase 1 metabolism is affected more than the phase 2. Phase 2 metabolism is not affected much in the old age. And it is the phase 1 metabolism where majority of our drugs undergo phase 1 metabolism. So that is the reason majority of drugs can have a prolonged duration of action. So that is another very important thing which you should always know. Okay, so what about their temperature regulation?
They're more prone for hypothermia.
Why hypothermia more common?
Because of reduced muscle mass and reduced fat.
Fat is more.
Fat is
Increased actually in them. Why actually they are? First of all, thermoregulatory center of functioning is also reduced. Isn't it? Everywhere, that is what I was telling you, all functioning of all the organs is decreased. So that is very important that, so their muscle mass is decreased. They'll not be able to shiver much, isn't it? So because of thermoregulatory center is not functioning properly, muscle mass is also not effectively able to reduce shivering. So they are highly prone for, hypothermia. So that is why that is another very important thing. Post-operative hypothermia, intraoperative hypothermia is very, very common in them, especially when they are posted for prolonged surgeries. So you have to maintain the temperature. You have to monitor the temperature. You have to use measures to see that they don't lose much of the temperature intraoperatively and postoperatively. So that is another very important thing regarding. And what about the regional anesthesia for these patients?
They'll have
Anesthesia? Yeah.
reduced intervertebral space will be there.
Okay. Because of
Calcified.
calcification of the interspinous, supraspinous, ligament of fleum, everything gets calcified. So you may be able to feel the spines very easily, but your needle, you may not be able to pass through the midline. So what you may have to go for, use now, what technique?
Ultrasound guided.
Ultrasound guided or otherwise paramedian. Paramedian technique. Midline approach may be very difficult. Many times you must have found, isn't it? So whole thing is calcified. The whole spine is calcified. So probably many times you may have to go through a paramedian technique. So that is one thing you should always remember about. And what about their epidural and then intrathecal dose requirement?
Reduced.
Why epidural dose is why it is reduced?
Plasma concentration is increased. Volume.
Epidural dose. Epidural dose means where you inject into the epidural space. Why you have to reduce the dose in the epidural space?
Increased sensitivity to the local anesthetic.
One is increased sensitivity of the nerves to the local anesthetics. Okay, fine. Because myelination starts decreasing in them as the age advances. And more fibrous tissue will start within the nerves also. So that is another very important. So they become very, very sensitive to the local anesthetic, their nerves. And what is more important than that? Normally, when you inject into the epidural space, any drug, there will be some amount of space in the intervertebral foramen through which the spinal nerves will be passing away from the spinal cord. So that amount of space which is there normally, some amount of leaking of this epidural drug will occur normally in younger patients. That is why the younger patients require slightly higher volume to compensate for that leak going into the paravertebral space. So as the age advances, there is more calcification of these spaces around these nerves, the intervertebral spaces also. there is these nerves will be snugly fitted through the intervertebral foramen, and they are passing across without hardly any space around these nerves. So there is no question of the epidural volume leaking into the paravertebral space. So whatever you inject, it will remain in the epidural space. So that is another reason it is said that the requirement is decreased. Of course, the intrathecal requirement also decreases because the CSF volume comes down. The nerves are also more sensitive to local anesthetics. So that is another thing about decrease in the requirement. Again, positioning of these patients for spinal or epidural, is it easy?
Oh, it is difficult
Difficult.
because they'll have joint stiffness.
Yes.
And age-related spinal deformities might be
Correct.
present.
So all these are the problems again they can have. So it is very difficult to flex their back. So because lack of flexion means the interlaminar space will not open up. So again, that will be a difficulty as far as the central neuraxial blocks are concerned. Okay. What about the drug dose for these patients?
We should reduce the dose and should give in a titrated dose.
Why should you reduce the dose? What
Because
is the problem as far as dose reduction is concerned?
one, plasma concentration is increased, and elimination half-life is also increased.
Prolonged.
Prolonged.
Because the liver is not functioning properly, and all the functioning of all the tissues will come down, so including liver and kidney. So the metabolism of the drugs may get delayed. So that is the reason why their requirement comes down. So another thing is about the CNS changes that occur, isn't it? What are the CNS changes as far as the pharmacodynamics of these drugs are concerned? What about the brain mass?
Reduces these
Reduce
sulci and
almost.
gyri are
Yeah, so it will be by 70-year age, it would have decreased by 200 grams. In 20-year-old, it will be 1,400. By 70 years, it is reduced to 1,200 grams. So decreased brain mass is there. And what about the MAC value of the inhalation anesthetic agents?
Decreased.
Yeah, how much it will decrease? Usually after 40 years, for every decade of life, how much decrease in the
10
MAC
to
value?
15%.
Every decade after 40 years, 6% decrease in the MAC value of it. Every decade, say suppose patient is 80-year-old. So every decade after 40 years means there are 4 decades.
24.
4 decades, 6%, 24% decrease in the MAC value. So they're more sensitive for the inhalation anesthetic agents, and also they are more sensitive for opioids. Then they are very sensitive for the IV anesthetic agents, isn't it? So that is why, and the metabolism is also affected, pharmacokinetics is also affected. So that is why the drug dose, you have to be extremely careful. You have to go for a lower dose. All the drugs, all hypnotics and opioid analgesics requirement comes down by 30 to 50%. So you have to reduce by 30 to 50% of the drug dose. So especially like, for example, propofol requirement. What will be the propofol requirement per kg body weight in an 80-year-old patient?
1 mg per kg.
Usually about 1.5. Usually,
1.5.
Younger children, they require 3 milligrams.
Yes.
And 20 to 40-year-old, it's 2.5 kg body weight. 40 to 60 is 2 milligram per kg body weight. 60 to 80 is roughly about 1.5 milligram per kg body weight. Above 80 is 1 milligram per kg. That's how, the drug dose requirement will be drastically decreased. So you have to be extremely careful the use of these drugs. And another important thing is they'll have a slow circulation. When you give any bolus drug, for example, now when you give propofol or thiopentone, it will take a longer time to reach the brain.
Peak effect.
the arm brain circulation time is prolonged.
Prolonged.
So you have to really wait for giving a further dose, a second dose, when you are injecting. So many times it is always better to go for an infusion of propofol for induction. Like, in many of the books, it is said that you go for a 400 micrograms per kg per minute infusion, slow infusion, and see the continuous eyelash reflex, because it will take a longer time for eyelash reflex to, be upturned or to be inhibited. So that is why slow circulation is very common in these patients because of the slow cardiac output. So you have to be careful. So these are certain changes as far as their physiology is concerned. The another very important thing is they'll have a lot of comorbid conditions, and they'll also have polypharmacy. So they'll be on multiple drugs. And all these drugs, you have to know all the comorbid conditions. You have to really study when you are doing a pre-anesthetic evaluation in these patients. So polypharmacy plus, why polypharmacy? Because of multiple comorbid conditions. And each comorbid condition, it will have its own effect on our anesthetic management, isn't it? So for example, now patient with cardiac failure, because they are highly prone for cardiac failure, your anesthetic management entirely differs, isn't it? Okay. Now, these are very important pre-anesthetic evaluation. You have to keep all these physiological changes in your mind when you are doing a pre-anesthetic evaluation. Okay, now your patient is posted for cataract surgery. And one thing is, probably you may be asked to be there for giving monitored anesthesia care. We'll just check that, or sometimes you may require to give general anesthesia for these patients. Okay, so how do you investigate these patients if they are posted for only cataract surgery under topical or some regional anesthesia? What investigations you would be doing?
So this is a low risk surgery for a high risk patient.
Okay.
So usually for a low risk surgery, if ASA 1 and 2, we won't ask for any uh, investigation. But since it's a high risk patient, we would definitely ask for all the investigation that is required for their comorbid condition to optimize them prior to the surgery.
So if you think that, it's only a cataract surgery under topical or under regional anesthesia as such, you need not have to ask for too many investigations, because it's a low risk surgery and you don't require. But if you think that patient is not going to be cooperative and patient may require general endotracheal anesthesia or general anesthesia with a supraglottic airway device, then definitely you have to really assess his all the systems, because invariably there'll be a lot of comorbid conditions. It is always better to assess before taking up. That is one thing. Suppose if the patients are on, majority of these patients can be on aspirin. Do you want to stop aspirin before taking up, or no need if the
No
surgery
need.
is done?
No need. No need, sir.
Okay. What about clopidogrel?
Even we can continue with clopidogrel. Even
Suppose they are going to do a retrobulbar block.
we check with the INR, and if the INR,
Clopidogrel, it will not change INR. It is only acting on the platelets. Nothing to do with the prothrombin time. That you should always realize. If a patient is on a dual antiplatelet drugs, the prothrombin time will be normal only. It will not be affected much. So if they are planning for a retrobulbar block, you'll have to discuss with the ophthalmologist. So it is better not to continue in such situation. Aspirin you can continue. What about warfarin?
for warfarin we check the INR.
The
If it
INR
is
definitely
within normal range, then it is.
No, it cannot be normal, isn't it? If the patient is on warfarin, it will be more than 1.5. Will you want to stop, or would you like to
We
continue?
want to stop because of risk of
No need,
bleeding.
no need for cataract surgery being done under topical anesthesia. If they're planning for retrobulbar block,
Bulbar block, we need
We
to.
need to.
yeah, then you may have to again discuss. That is not that all the time it need not have to be stopped, but you can just have a discussion with the ophthalmologist, and if he thinks that there is a chance of hemorrhage behind the globe,
Retrobulbar hemorrhage.
stop. So that is because why I ask you this is many of these patients can be an anti-platelet drug therapy and anticoagulant, isn't it? So that is why you should be knowing. So what are the common regional anesthesia techniques that are used for cataract surgery?
Peribulbar block,
Okay, one is peripulbar block,
retrobulbar
Retrobulbar
block,
block.
bulbar block, okay,
Subtenon's block.
actinon block, or topical.
Topical.
Yeah, so you should know slightly more about these blocks and their complications. Because suddenly, especially the retrobulbar block can produce hemorrhage, bleeding that is behind the globe. And second problem, there can be very rarely perforation of the eyeball, especially if the length of especially like you said that, corneal to retinal length is more than 25
Axial length.
axial length.
If
So,
it is more than 26 mm.
millimeters, there can be chances of perforating the globe.
Perforating
Always. So that is why you have to know what kind of a block they are going to do. And basic things about these blocks you should always know about. And if you are asked to give sedation intraoperatively, now what sedatives you would like to use and how you want to use?
a low dose of benzodiazepines, and low dose of opioids.
Yeah, very important that it's very, carefully you have to titrate the opiates. Fentanyl you can definitely use, or remifentanil is better drug, and midazolam you can always use. So these drugs you have to really titrate. Okay, and what intraoperative problems you can expect when you are doing a MAC for these patients?
Sudden raise in intraocular pressure.
No,
So
already, they would be keeping the patient head up to reduce the intraocular pressures, isn't it? So other problems, for you as such, patient can become restless.
Patient can be restless.
Can become hypoxic because, the whole face
There
is
is
covered.
draping over the
He may not be
face,
able
and
to
patient
breathe,
may be
isn't it?
uncomfortable.
So, would you like to, usually do you keep some oxygen supplementation for these
Yes,
patients?
sir. We give nasal prongs.
Yeah, nasal prong. So that is one thing because everything is covered. Chances of restlessness can be due to hypoxia or hypercarbia. Both can occur. So that is one thing. Second thing is claustrophobia.
Claustrophobia.
And this is another problem that can occur. So suppose if the patient becomes restless because of claustrophobia and his blood pressure is also rising, then his blood pressure also will start shooting up. So he may not remain still. So how are you going to manage this?
We usually ask the surgeon to pause the surgery, and then we talk to the patient, we reassure him, and then we
Do you
can
want to
all.
postpone the surgery?
No, sir. Just momentarily pause the surgery for a few
No, but
minutes.
many times, when they have claustrophobia, you just cannot cover their face. Again, the same anxiety, all those things will start. Many times you have to postpone surgery, you have to, because, you would not have done any investigations and you would not have assessed this patient. Isn't it? For providing, these patients require GA. So definitely you may have to reassess these patients, postponing that day, doing all investigations, assessing these patients, then only you have to take up them for GA. Many times if you are asked to give GA, so better not to give GA because these patients are not prepared. And another thing is, what about their, nil per oral status?
They
NPO
usually
should be
it's
adequate, sir.
but in this kind of patients, they just come with a glass of milk in the morning, just 2 hours of NPO. That is
Because
what they
many
advise.
times the ophthalmologist, recently my sister underwent, she is 76-year-old. She underwent cataract surgery. She was asked to take breakfast and then come to the OT. Because, many of these patients may be full stomach. And if you are asked to convert to GA, you should definitely refuse, because you will produce more problems for these patients before assessing. So what are the conditions in which you usually the cataract surgery you are not able to take up immediately and you may have to postpone of the patients having problems? What problems the patient has, you may have to postpone the surgery. Not intraoperatively, before only, when you are assessing the patient. I'll give you a clue. For example, the patient has had an MI recently. It is about only 20 days. So how long you should wait actually after an MI?
6 weeks.
Minimum 30 days.
30 days.
Okay, suppose the patient has had a revascularization procedure, has had a stenting done. So
If
how
it is
long?
not, if it is as per guidelines, if it is not an emergency procedure, you can always wait till 6 months and then go for.
Yeah, it is not an emergency.
It's not an emergency, so we can
But
wait for.
as early as possible, if the patient has got problems with his vision, there is always a possibility of increased incidence of fall, and then have fractures and other things. So once you know that he has got a diminished vision and it's because of cataract, as early as possible, the cataract surgery has to be done. So you can wait for about 3 months or minimum 6 weeks after drug-eluting stent. You need not have to stop the dual antiplatelet therapy, and the surgery can be done now. Phacoemulsification is being done, and so they can do under topical. Definitely, you can make them do the surgery after about 6 weeks. So that is another time when you may have to may not be able to take up immediately. And patients in cardiac failure, again, you have to optimize, isn't it? If the patient has cardiac failure, he will not be able to lie down. So unless you optimize, you cannot take up these patients for surgery, isn't it? Okay. So what about if you are asked to give GA for this patient? For cataract?
Pre-medication, we would give a H2 receptor antagonist.
No, what problems you anticipate?
While mask ventilation, we might
That is already
compress the globe.
Okay.
So compressing the globe can cause increase in IOP.
Okay.
And while intubation also, intraocular pressure increases 10 to 20
You
mmHg.
want to intubate or you want to use a supraglottic airway?
Since it's a short procedure, we would like to use a supraglottic airway.
So
and
you can
LMA would be
avoid
preferable.
all problems associated with laryngoscopy and intubation, isn't it? You can definitely use a supraglottic airway device. And can you allow the patient to breathe spontaneously?
Yes.
Yeah, because short procedure.
Short procedure,
The
we can
effect
allow
of
it.
inhalational anesthetic agents on IOP.
Sorry, sir.
Effect of inhalational anesthetic agents on intraocular pressure.
It does not affect the intraocular pressure.
They'll reduce. Your propofol will reduce, your thiopentone will reduce, your inhalation anesthetic agents like sevoflurane, isoflurane, desflurane, all of them will reduce. So they are actually advantageous, provided you maintain, you prevent hypoxia and hypercarbia intraoperative. Because hypoxia and hypercarbia will increase the IOP. As long as you can prevent, you can definitely use your pressure support ventilation. Allow the patient to breathe spontaneously with a supraglottic airway device. Don't use any muscle relaxants like non-depolarizers. So you can, as soon as the surgery is over, you can definitely, as early as possible, you can take out the supraglottic airway device once they are completely awake, isn't it? So these things you can always make sure. So what kind of a supraglottic airway device would be ideal in this? Of course, you have to make sure that they are nil for oral status. They cannot have their breakfast and then come for surgery. You have to really prepare these patients. Okay, which particular supraglottic airway device is very popular for eye surgeries?
Supreme or iGel?
So not Supreme or iGel. You can definitely use Supreme or iGel, but one of the most simple uh, laryngeal mask airway.
Proceed.
Proceed.
Flexible LMA
Flexible.
or reinforced LMA. That is ideal because it has got a longer tube. So your connection to your circuit also will be quite away and it will not rotate inside. So flexible LMAs are very, very popular as far as or reinforced LMAs, they are also called as LMAR. They are very popular, especially in pediatric age group for cataract surgery. I have seen one ophthalmic hospitals where they do so many cataract surgeries for pediatrics. The anesthesiologist was using only LMAR, reinforced LMA. So that way it is always there, one can use. Again, these patients can develop postoperative delirium, postoperative cognitive dysfunction is also very, very common. They are posted for not only cataract surgery under GA, for any other surgery. So you'll have to take care, especially post-op pain is one of the problems in developing postoperative delirium. So you have to provide very good post-op analgesia. So this is about the geriatric patient. Any doubts you have? Exactly 7 and 2 minutes. We discussed most of the problems associated with geriatric. Any doubts you have? No, when you must have studied geriatrics, isn't it? So you might have had some doubts when you are reading. You did not develop any doubt. Very good. Fantastic. So we are not finding anything also in the chat box. So what is the next this thing we'll be doing? Next week I'm not there.
Sir, tonsils, sir.
Next week I'm not there. So we'll be doing on today is 2nd, isn't it? So otherwise we should have done on 8th. So shall we'll have
15, 16.
22nd, sir.
15th, 16th.
15, 16, sir.
So can we have on 14th, 15th?
Okay, sir.
14th is Thursday, 15th is Friday.
Okay, sir.
So we'll have those 2 days, 14th and 15th.
Okay,
Because
sir.
next week, 20th and all, national conference is there in Patna. I'm going to national conference. So that is why only those 2 days. And again, after probably 15th, if we are doing 22nd and again 29th, 30th, we can do again.
Okay, sir.
4 days. Okay, in November. So let's have on 15th, sorry, 14th, 15th.
Yes, sir.